Hi friends, I am Dr. B.B. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the strangulated inguinal hernia. It is the protrusion of a viscera or a part of the. First of all, I will discuss about the hernia. It is a protrusion of a viscera or a part of it into the inguinal canal, which has three parts: superficial inguinal ring, deep inguinal ring, and inguinal canal. Superficial inguinal ring. It is a triangular opening in the aponeurosis of the external oblique muscle. The ring is bounded by superior medial and inferolateral crust joined by crisscross intercrural fibers. Normally, it won't allow even the little finger. Deep inguinal ring. It lies above the inguinal ligament and midway between symphysis pubis and anterior superior iliac spine. It is a U-shaped condensation of transversalis fascia and open above. Inguinal canal. In infants, the superficial and deep rings are superimposed. In adults, it is about 1.5 inches long, directed downwards and medially. In males, transmits the spermatic cord, ilioinguinal nerve, and genital branch of genitofemoral nerve. In the female, have a round ligament replaces the spermatic cord. Boundaries of inguinal canal. Posteriorly, internal oblique, anteriorly internal oblique fiber, superiorly internal oblique and inferiorly inguinal ligament. Strangulated inguinal hernia. A hernia becomes strangulated when blood supply of its contents is seriously impaired, rendering gangrene imminent. Gangrene form after 5 hours after strangulation. Indirect inguinal hernia usually strangulates. Direct hernia rarely strangulates due to its wide neck. Sometimes the hernia strangulates on the first occasion that it descends. More often, strangulation occurs in patients who have worn truss for a long time and in those with a partially reducible or irreducible hernia. Constricting agents are neck of the sac, external abdominal ring in children, and rarely adhesions within the sac. Contents. Commonest is the small intestine. Next comes the omentum. Clinical features. Pain is the first symptom and occurs over the hernia, followed by generalized abdominal pain, paroxysmal in character and present at umbilicus. Vomiting. Repeated vomiting may be there. Tenderness. The swelling is tense and tender and no impulse on coughing. The patient is critically ill and treatment is urgent. If not attended, may lead to gangrene and paralytic ileus. Spontaneous cessation of pain is a grave symptom. It may be strangulated. Richter's hernia. Strangulated partial enterocele. Strangulated omentocele. Strangulation during infancy. The incidence is high in a female child. The content may be ovary or fallopian tube or both. Maydl's hernia. The strangulated loop of the W lies within the abdomen, so local tenderness is absent. At operation, two normal looking loops of intestine are present in the sac. After the obstruction have been relieved, the strangulated loop will become apparent if traction is exerted on the middle limb of the loops occupying the sac. Treatment. The treatment of choice is the emergency operation. If dehydration and collapse is there, intravenous fluid replacement and gastric aspiration are valuable. The stomach is emptied before the anesthesia. If necessary, bladder also must be emptied by catheter. Herniotomy for strangulated hernia. Over the prominent part of the swelling, an incision is made, external oblique aponeurosis is exposed, and the sac with its coverings is seen issuing from superficial inguinal ring. It is possible to deliver the body of fundus of the sac with its coverings, and in males testes on the surface. Each layer covering the anterior surface of the body of the sac near the fundus is incised, and is possible it is stripped off the sac. The sac is then incised, the fluid there is mopped up or aspirated thoroughly, as it is highly infected. The external oblique aponeurosis and the superficial inguinal ring are divided. Returning to the sac, a finger is passed into the opening, and employing the finger as a guide, the sac is slit along its length. If the constriction lies at a superficial inguinal ring or in the inguinal canal, it is readily divided by this procedure. If the constriction is at a deep inguinal ring, by applying hemostats to the cut edge of the neck of the sac and drawing them downwards and retracting the internal oblique upwards, it may be possible to continue splitting up the sac over the finger beyond the point of constriction. When the constriction is too tight to admit the finger, a grooved director is inserted, and the neck of the sac is divided with a hernia knife in an upward and inward direction, parallel to the inferior epigastric artery under vision. Once the constricting agent is divided, the strangulated contents can be drawn down. Devitalized omentum is excised after being securely ligated by interlocking stitches if bulky. Viable intestine is returned to the peritoneal cavity. Doubtfully viable and gangrenous intestine is excised. If the sac is of moderate size and can be separated easily from its coverings, it is excised and closed by pus sting suture. If the sac is large and adherent, excision is the rule. Having tied off the neck of the sac, hemiorrhaphy can be carried out. Conservative measures. Indications. Patients having reducible hernia which is strangulated for less than 4 hours, in infants less than 6 hours. In elderly patients, gangrene occurs early and with few signs, so these measures may be useful. Nursing in a warmed bed to promote muscular relaxation, elevation of the foot end of bed to reduce congestion, administration of full dose of pre-medication like omnopon and scopolamine. Infants are given chloral hydrate. Half an hour after the foregoing, the hernia is reviewed. In a few instances, the hernia will have reduced spontaneously. In number of others, reduction is easily obtained by gentle taxis. The thigh is flexed and internally rotated in order to relax the pillars of the external ring. The fundus is supported with one hand while the contents of the neck of the sac are kneaded with the finger of the other hand, so that the contents which are lost extruded are the first to be reduced. In these patients, emergency operation is avoided and elective herniorrhaphy is performed. Alternatively, a pad and spica bandage are applied, and the patient can then arrange a convenient date for operation, or be fitted with a truss if operation is contraindicated. Vigorous taxis has no role in moderate surgery. That's all about the strangulated hernia, and in the next video I will discuss about some other disease. Thank you.